Very delighted to bring Tara Marshall in today to talk about a key project that she has been delivering and hopefully some really great insights from These Hands Academy. And questions in the chat, please do put any questions or comments, any thoughts or feedback in the chat, any experiences you've had, and at the end we'll have a Q&A session. So everybody who's brave, put your questions in the Q&A and we'll get those questions asked. And if you've got any thoughts or ideas, put them in the chat and we'll bring them to you. Thank you for joining us today, Tara. It's fantastic to have you with us.
You're more than welcome.
So without further ado, I'll pass over to you to talk about today's topic. Thank you.
Fabulous. Let me just pop my slides into present mode and we'll get started. So thank you so much for inviting me here today to talk to you on your hospital to community webinar, because it's really important for people to be looked after in their own homes as much as it is in a hospital, and we're starting to think how we deliver that. So my name's Tara Marshall. I'm the founder of These Hands Academy. I trained as a nurse 25 years ago and specialised in critical care. I then completed a master's degree in patient safety and went on to work in the patient safety collaboratives, supporting system-wide quality improvement programmes. Our company, These Hands Academy, it was formed in 2023, but it was designed to work with our integrated care boards to support system-wide transformation projects through behaviour change, because we knew we could do this at pace. And our work aims to improve standards, create efficiencies and inform future planning. Our team now comprises of myself, Sarah, who supports our day-to-day running, and Caroline, who is our data analyst. And between us, we've got 55 years of experience of working across healthcare services. And at These Hands Academy, we offer 3 flagship services. One of them is the Safe Hands programme, where we provide training focused on patient safety, quality improvement and human factors, and that's around behaviour change. We then offer implementation support for the whole life cycle of somebody's programme, and specifically for today it's around telehealth. And we offer that because we want to create a system-wide change, and that change only happens if we look after the whole life cycle. Our evaluations provide an independent view, bringing both together the qualitative and quantitative data, but focusing on outcomes at each system level, and mostly to focus on the people that are the beneficiaries of these projects, to see how they work best for them. And the one I'm going to talk to you today is the one that we're supporting across Leicester, Leicestershire and Rutland, who are implementing a telehealth service across their social care services to connect their hospital to community. The Darcy report talks around sickness to prevention, and for us that means managing deterioration proactively, moving from that reactive process that we currently have in place to one that's proactive and starting to buy more time to make decision makings. From hospital to community, again, what we're going to talk about today, but this is about enabling communities to be better digitally enabled, but also thinking about certainly where our evaluations are is where does that add value to people? How do we know that we're putting the right equipment in the right place that's going to be used to the best of its effectiveness? And we know by doing this, we will prevent harm. So you've heard a bit about us. Let's hear a little bit about you. By now you will have got your Mentimeter set up on your phones.
If anybody didn't see it at the start of the session, I've just re-put the link in the chat, so please do have a look at that. And what we'll do is we'll look at those that have put their results in already, and we'll just give you a couple of minutes for those that haven't put your details in yet to get those up. So far we've got 10 people, 11 from the NHS, 1 from primary care, How do you get from social care? We've got, having a look at the introductions in the chat, I think we've got some more folks from primary care or supporting primary care delivery, perhaps. So that's 13 from the NHS. So it looks, Tara, like we need to do more to promote our sessions to the social care and primary care community.
That's good to know, though. And it's great that everybody's here.
Absolutely.
So what some of the challenges are in these big system-wide programs is being able to involve the whole system. It is huge. And the NHS as itself is one big organisation. But when we start talking about social care, there are thousands of providers that work with our social care services. So reaching them is increasingly a challenge.
I think that's it for the results.
Okay. We carry on. Just put that back on. There we go. So the majority of you are from healthcare and from the NHS, which is really interesting as we start to think about from hospital to community. And what would be nice if when you start and you leave this session, that you take this information with you and share it with your primary care colleagues. Because part of the Connected Care programme was connecting social care into healthcare. And we did that using a telehealth service, but we had one vision for this, and this was our mission statement. Wouldn't it be amazing if everyone that was worried about a person could hand over information clearly and confidently, be understood and heard? And that sounds really simple, but in any system, those systems are full of complexities. Yes, is the answer to that. So when we think about where the audience in this room, we're talking predominantly to NHS people in this webinar, but actually when people are worried about somebody, a lot of that worry starts at home. And this is where we can absolutely get the greatest intervention. The Connected Care programmes had a series of objectives that we wanted to get to. And it meant working as a system versus local and national contracting. So when we talk about the providers of care homes, there's 5,500 of them across the UK. And Leicester, Leicestershire and Rutland have the same challenges as everybody else does in trying to bring those into a system-wide project. But also we wanted to enhance the current ways of working and create a culture shift that goes from one organisation to many, and improve the confidence by engaging people and their families to be more inclusive in the way that they work across social care, but also for healthcare, how they include people in social care activities. And we already have the virtual ward where we could start to think about how we interfaced with those. But also we now have a lot of digital care records that equally needed to be interfaced with. And the telehealth system in choice that the Midlands chose was the Wizan Blue Box. And some of you will be familiar with that in your virtual ward models already. So we had a timeline that was very iterative. We did a lot of quality improvement cycles at each step of the way. And we had a really short review period so that we could create a longer deployment to embed the learning and align that to systems that were also being rolled out across the region, but make sure that we were in time with them and making equally sure that we weren't overloading our care homes and the staff within them with work that we needed them to do. So we needed to keep this as simple as we could, but our initial evaluation already proved that we could save over £600,000 in savings. So we very quickly planned to scale that and keep growing the community of people using it whilst evaluating the impact that it was having. We, at 12 months, did another evaluation specifically focused on the people that were using it. And whilst we could demonstrate system savings were continuing, we could really demonstrate that people that were using it in some ways differently in different areas. And this gave us food for thought. When we talk about patient safety, we often talk about things that go wrong, and we talk about that in the 10% of things that go wrong, but there's 90% of things that we can learn from that go right. And what we wanted to do was unpick those golden nuggets through this programme to see how, A, we could scale it at pace, but also start to impact more and more people with a system like this. We know that by the end of it, we could unlock further funding, and we now have over 1/3 of homes across Leicester, Leicestershire and Rutland. So now we've moved from pilot to scale, and we're in a space where people are starting to build a community of practice and starting to share their own ideas. And we have an ambition to scale that even further to 75%. So Leicester, Leicestershire and Rutland, like many of the ICBs, it's one of the 42 across England, but it houses 1.1 million people. It has 3 universities, but it's also one of the most diverse areas in the Midlands. And it has huge disparities related to health and social care provision, both in access geographically, but also demographically. And like we said earlier, they are not on their own with an array of providers. There are over 17,000 care homes and a growing number of domiciliary care services that when we start using digital technology, we need to interface all of that into. Otherwise, that becomes even more complicated than it was before. 70% of our care homes across the UK are listed as residential homes, and that means that they're supposed to be a home from home. So our hospital at home services should technically be able to access them as well. We have 137 GPs in LLR. We have 3 acute hospitals, and between that, there's 55,000 staff in the workforce to engage with on this project. So we started to build some building blocks on what we knew was already there and centred that around some of the healthcare principles in patient safety. Managing deterioration has a set of tools that's been used across the NHS for many years now, and it's established and validated, and we wanted to spread that into social care services. We wanted to continue that digital journey for them, but also think about how we could buy more time for proactive care and prevent people not only going into hospital, but prevent harm through doing so in the first place. When people go into hospital and they're frail, they're often there for an average of 10 days, and they go through a period of deconditioning. And for people in a residential home, that can mean moving to a care home on the way back. So not only have they had to go into hospital, they now have to move home on the way out. And for many, that wasn't their choice at the beginning. We also needed to align this to every other project that was running. Underpinning all of our managing deterioration tools is the peer framework, and this is a framework that runs across a big quality improvement programme across the NHS. Residential homes are where the staff in those homes, people know them the best. And those soft signs, those worries and concerns are often the places that we fail to hear at the front door of a hospital. But they hold the most information, and they start to move that dial from response when somebody's really unwell to prevention. And that is the opportunity to make a difference. By using soft signs, we can enable people to really translate their worries and concerns and take a set of vital signs and pop that into the news score. The news score is used across all of our NHS services, our mental health services and primary care services, and more starting to work across our social care and supported living environments. It's now used as a common language. It's very much a nursing tool, but it's used as a common language where we can start to think about how we track and trigger people across not only a hospital now, but across a whole system. And when we do this digitally, we can start to think about a baseline for people as they live in the environments that they do, and certainly in their own homes. And we're gathering this now with many devices, not just telehealth, but also wearables. So why do we want to do this digitally? Well, this is a chart that would normally be on the end of somebody's bed in a hospital, and some hospitals still are on paper. And those charts are difficult to interpret at the best of times. By doing this digitally, we start to improve the quality of the information that moves from A to B. The signature on this chart is particularly difficult to read. And when we start to map this through using a digital process, we still see people in hospitals writing this on their gloves, on bits of paper, and going to the nearest desktop. What we did with our care homes is use Bluetooth enabled equipment to prevent that activity for even starting. So they started with a system that didn't involve paper at all. They started this program through a digital readiness checklist, and at that point started to think about how they were going to use all of this from one end at the beginning right out to the other end, where we can have an auditable trail of that data entry, which safeguards the care homes and the residents in them. It equally, if somebody did have a complaint they needed to process, it enables people to very quickly find that data and assure friends and relatives that that activity has taken place. In hospitals, this is really difficult to do, especially when people are still on paper charts, because they often go missing. So we wanted to make sure that our care homes were in a place of a gold standard, but also be able to work with emergency preparedness. We still knew that they had printers at some places in care homes across the region, and some are also using the red bag tool. So for those of you in the NHS at the front door, you'll probably be familiar with the red bag. To do this digitally, it means that we can take all of that information and transfer it straight through with that resident, rather than rely on a paper system that transferred that through in a physical bag with that resident. And when that information goes through a lot of people and we have a lot of conversations, they can get lost in translation. So what we wanted to do was really unpick that I'm worried about somebody's not really looking that well today, they're off their legs. What does that mean? In primary care, they often know what that means. But when we go to a front door of a hospital, that often gets lost in translation. And we also needed to unpick 55,000 people to have one conversation that really mattered, rather than several that got mixed up along the way. And the way that we did that was translating that into that news score. It's one of the most important indicators of something and somebody being unwell. And numbers often stay the same as we transverse them through different sectors and different communication systems, whereas long sentences are more difficult to unpick. So essentially, we turn those long sentences into a coded conversation. So whilst we're talking about health and social care, and we know that most of you here are from the NHS, I suppose my next question now for you is to say, how many years of experience have we got in the room working within them? So if you could go back to your Mentimeter, I can see your answers coming in on the screen. And let's see how many years people have worked in each sector.
So in addition to this, Tara, which is giving us a real insight into how long people are, and there's some long-serving folks in the group today. Thank you, everybody. I've also asked them what challenges they face in working collaboratively, just to see what kind of problems that they have. So if you're happy to, once we've had a look at this, I'll just have a quick look at some of those responses, if that's okay.
Yeah, that's great.
So we have some long-serving folks. That's a lot of years of experience collectively between us all. Is that it? Everybody completed that question?
So we've got, what we got? We've got well over 150 years in the room.
It's amazing. And then in terms of the challenges, so I sort of asked people what were the biggest challenges in working collaboratively to deliver patient-centered services, and you'd be unsurprised to see some of these answers. I think staff too busy to engage, and this might be something that you can focus on how you dealt with some of those challenges when you were faced with this. No staff time, system interaction is a barrier yet to be overcome, capacity to commit to the work, services looking at their own interests and not at the patient. So some of that change management stuff maybe. Budget, lack of use of technology and consistent technology and skills, conflicting priorities, capacity, multiple systems. Asking staff to change, to work on change ideas whilst delivering their BAU work. How can we implement new ways of working whilst demand and capacity remains an issue? Resources, yeah. So I just thought it'd be interesting to see what challenges people thought, and then how did you tackle some of those things as you talk about the solutions that you put in place. Thank you for those responses, everybody. Change fatigue, yes. I'll swap back over to you, Tara, so that you can
That's okay.
Carry on.
Fab. There we go. I'll just pop it back up. That is, it's absolutely some of the challenges that we had to face. And there were many of them, and primary care and those three sectors often don't talk to each other very well. So we really had to focus on what was in it for them. And we went to an awful lot of stakeholder meetings, and these are often a lot of our groups. So we set about how we separated out where our impact would be, and allowed us to work with all of the services. We really engaged with our local authorities. We also engaged with our healthcare team, and we sat in the middle of them and almost brought them into a series of webinars so they could talk to each other on how we would start to think about interfacing what is one appears to be a simple system across them all. But alongside all of these projects that were running was our project, but also the digital health record. And there was, like, as you've identified in some of your questions, there was many other projects going on, and how do we keep people engaged in the same one? And that was about working collaboratively with the people on those projects as well, because what we needed to do for our care homes, they have an enormous amount of wraparound support that we needed to find, and the only way that we can find them was by interfacing with them. So we spent a lot of time knocking on the front door saying, who do you send your residents to, and how many people do to work with care homes? And if you look at an organisation like Specsavers, who knew that they went into care homes regularly to do audiology? But they do. So there's an opportunity to start thinking about how we work with them as well. For our homes, what we wanted to do, and from a managing deterioration perspective, was to keep that dial into the green. So we needed to focus on how the care homes interfaced with their GP. We knew that nationally contracts supported that through the DES contract and the enhanced care home framework, but we want equally, we'd got a responder network. We have an out of hours system in Leicester, Leicestershire and Rutland, and we also have our 111 services. So those also tripped over each other. We have a growing number of domiciliary care services that we equally needed to interface with. So the way that we talk to people is that we said, by the time we've got people in the red actually our opportunity for an intervention preventing harm has taken place, and that's gone past us. So we needed to focus on where our opportunities were to align our national policy, but also our activity on the floor. And that was about taking measurements regularly in care homes and seeing where that data led us as well. And interoperability was a huge challenge. The Whiz-Am Blue box that was in use had everything in there to take a set of vital signs. It was all Bluetooth enabled, and we could use this per care home or per therapy team going out to a care home. And we've used it in both places. And that way we've got people using the same system for very different reasons. But it supported the rollout of System 1 that's going out now to all of our care homes. And that is going to continue the rollout into the next few years. So we will align that now with the Frailty Virtual Ward and other systems using System 1, such as our pharmacies. We designed an onboarding process that not just only engaged our care homes, but engaged other people in the system as well. And we're continuously learning from them. We set up a digital process for them right from the beginning to right to the end. And we're still in touch with our care homes all the way along. And we do this through a variety of ways. We haven't specifically gone down one road. We have tailored clinical support for them. And we understand that our care homes have a high turnover of staff. So that opportunity and that door is always open for them. And we do that not only through us as a company, but through the Providing Care Services, which is a Leicester Partnership Trust initiative. So we interface with those services as well. And we also support our local authorities in their compliance checks. So we start to interface our product with other people's as well as the blue box interfacing with other services. And we've now moved from pilot to scale very quickly in that timeline. We started with 20 boxes, and on there we could support 800 residents. We've now moved that dial much further into the green, and we have over 3,500 residents in this system. It is growing daily, and the more care homes are starting to talk to each other and develop their own community of practice, it's starting to grow organically. We have over 50% of our city homes using this, and they use it very differently to some of ours in Rutland because the distance to hospital is different. So we find that our care homes in the city often rely on 111 services much more than we do in Rutland, where they will rely on therapy services, and they're much more engaged in managing deterioration early. And some of this is about their positioning within the region. The map at the back of you, or the back of the slide, is actually where these boxes are, and they are mapped across the whole system. And we know when they're being used and not used. And that way we can start to think about how we rehome them if we need to. But we also can get in touch with care homes and go back to them and say, how can we offer a bit more support? And then we uncovered a golden nugget as part of our initial 20 boxes, and Chris, who is the amazing person that he is, and I will introduce you to him later. But in patient safety, we often talk about that 10% of harm. Well, Chris is part of our 90% of what we learnt, and we learnt an awful lot around working with people like Chris. And Chris has a learning disability, but he's also a gold medal winner. And he's got several that we uncovered during our initial interviews with him. He's also anxious about his health, like many of us who live in the UK. This is it's not uncommon that we're worried about something. But he used to call 111 services 3 or 4 times a day. And we equipped him and his support workers with a Whiz-Am Blue box. And in 3 months, he started to call them less than 3 times a month. and 6 months later, he's out sailing, living the life he should be living. Now, we know that I've got a bucket list for if I gave you 20 years to add on to your lifespan, I'm sure most of you would be able to fill that list with things that you want to do. But for people with a learning disability, we know that they die 20 years earlier than the rest of us, and 42% of them have died an avoidable death. So this work is really important, that we start to change that dial specifically for that group of people. And they also face really huge challenges when they have to go into hospital. But as part of ringing 111 services, even if you rang them every time, 3 or 4 times a day like Chris did, there are times when you do have to go to hospital. And supporting the annual health check for people with a learning disability, this is a solution that's really helpful for them. The home where Chris lives had an isolated flu outbreak over this winter, and it's enabled them to connect with their healthcare services and keep people isolated and reduce the footfall through their homes. We went to one networking event with Chris and we helped him make a film about this because he wanted to share his story with other homes, and we now have a quarter of the homes with supported living homes across LLR on this system and in this programme, and that happened literally overnight. So our first evaluation that formed that £600,000 in savings really started to think about how we worked with this and how we introduced it to therapy teams and our domiciliary care teams. And we started to talk to individual companies, and we spent hours and days bringing those people into our webinars to make sure that everybody understood that we were doing. As part of our GP onboarding, we took those into the webinars too, but we also made one specifically for our GPs and gained this onboarding process through our emerging communities and really tapped into them. We also wanted to spend the money once. It's a limited amount of money and that we had to do this with. So we needed to make sure that the boxes were all in use, hence setting up the asset management system for them. But for homes that were introducing another system that didn't want to continue with this one and move on to a different system, we could do that because they were all using the News 2 score. But we supported them to come back to us, and we placed those boxes then in other places of need and charities and other areas where we felt that they would be really impactful, but also hadn't got any funding to do that with. So our care homes have continued to care for other people across the system. But we are absolutely aware that this programme and many other digital programmes create a digital divide. And what we're also trying to do when we rehome those boxes is support the reduction in that digital divide. We know that we have a community of people that are worried well and they are digitally enabled. But we also have those people that are at risk of not being digitally enabled and they are deteriorating unnoticed. And that's the bit that we really want to unpick. So in our evaluations, we pull together those active data sets. Specifically in LLR, it was around usage and it was around the asset management, and what wasn't being used we could put into areas that could use it. So we prevented that group of deteriorating unnoticed. We pulled in the system-wide data and aligned that with our activity data, but also our observation data. And when we talked to our care homes, we did hold structured interviews and they answered a lot of surveys, but they were keen to help us because we'd engaged them in the project all the way through and we kept them up to date with our case studies. We had our care homes presenting them at provider forums. We helped put them together, but essentially they presented their own case study, and that helped build that growing community. We now have over 40,000 observations banked in store that we can start to think about how we model this model further and how we take this model further. We have an average News 2 score that, for all of you in the NHS group, will be familiar with this. They have an average News score in care homes of 3 to 4, and that News score you wouldn't normally be allowed out of hospital with. But we know that it improved communication between all of their services because they told us it did. And we have several examples of that taking place. We know that 84% of our homes saw a reduction in avoidable admissions. And for some of them, that admission avoidance was significant. We saved almost 3 hours per week waiting on calls for our GPs because we could talk a common language, and that was that News score. We are starting to see conveyances change from conveyance to hospital to see and treat, and we have an aggregated return of investment of 80% on the use of this kind of project. And this project doesn't sit on its own. It sits alongside all of that wraparound engagement piece for our care homes. And we keep asking them, how does it feel for them? And this is their response. This isn't us. This is their response that we have taken back to the local authorities, the funders of this. And in our evaluation in your words, you can see this. You can pick that up from the website. It's sitting there in the back end. So do pick it up and read it. So how do we scale this model into something bigger than that? Well, LLR have 1.1 million people. The UK has 67 million people. All could benefit from using what is a standardised tool already in the NHS that we can use across our social care services. We are all living together with more complex conditions, and our families now traverse the globe. There are stark disparities of equity across every system and in the UK and equally across the world. But how we access care from rural areas can really be changed dramatically by using a system such as this. And equally, people on the peripheries can start to engage with services on either end. And take Chris, for instance, will access a hospital in the Leicester area. He will also access hospitals in Northampton, and those hospitals currently aren't using the same system. So for Chris, that information gets lost along the route and he has to start again. And he's not on his own in that challenge. So we really need to think about that interface and interoperability that we do when we start thinking about digital challenges. Innovation is often about disruption, and we wanted to disrupt the status quo. And we have done that in a way that's aligned itself to the system, but also to national strategy. From our care homes, this project has demonstrated how we can break that barrier between health and social care. We can break down the silos and we can collaboratively support each other to release time to care, but also improve outcomes. And at a system level, this project sits and interfaces with other objectives such as hospital at home and the virtual wards. Oh, there we go, sorry. And at a more national level, it's demonstrated the art of the possible within the integrated care systems. We have 11 ambulance trusts. We have just over 1,000 hospitals, but a mixture between NHS and private hospitals. We have those 17,000 care homes, and we have developed the foundations of what for LLR is an ambitious strategy for their virtual wards. But we need it to transcend both health and social care to support citizens, not just at home, but in their community as well. So where are we now? Well, we've met our target and gone way, way past that. We have people using this box regularly, and we have now created a demand for the data from our wraparound services. And in doing so, we have engaged them all into this project. We've shifted the conversation from lives saved to value added. And we have started to create a better equity across the system that builds resilience and improves outcomes. And by working with the most excluded, we have created services that are wholly inclusive. And I've talked about Chris a lot during this, and he's a very special person, and we supported him to make a film, but he's also inspired where we go with this next as well. And we're starting to inspire our universities and other organisations to think about what we do with the data and how we model this further for other countries. And we've also been very lucky to inspire some healthcare students at Cape Breton University, where they're thinking about their rural areas and the disparities in their systems. So Chris was with us when we made a film. He was also with us when we went to some awards, but this is part of the film that he made, and I'll share it with you now. And that hard work has paid off. We've been lucky enough to reach the finals in 2 HSJ events. In June, there was the Digital Awards, Connecting Health and Social Care. And in September, we were at the Patient Safety Awards for the Initiative of the Year for Learning Disabilities and for the community and for the Connected Care programme, of which we walked away with a high commendation. Chris went with us to both of those events and we danced the night away. It was a great place to go. So before we go into the Q&A session, I just want to leave you with something that really resonates with me, is sometimes when you look through a different lens, you really can see a different picture. You can use a single language and change outcomes for many people. But it's really important that we tap into those users and we recognise the courage it takes for them to speak out and help us learn. And my details are there. You'll get these slides out, and I'm going to stop sharing so that we can go into any questions, because I'm sure Joe's got many of them for us.
Yes, thank you, Tara. That was absolutely fascinating and a brilliant project, and just the results and how tangible those are. That was fantastic to see. We do have some questions that have come through, and just to frame it, I think the one thing that stood out for me most glaringly was the statistic that 42% of people with learning disabilities died from avoidable deaths, and that's just horrifying, isn't it? But then yes, to see Chris so enabled to support himself and his own anxiety about his health and care, that seemed incredibly liberating. So fantastic, well done, and congratulations.
Yeah, I'm a sailor myself, so I'm out sailing with him.
Brilliant, that's absolutely awesome. So I'll start. We've got a few questions through. I'll start with Steve Archer's questions. Is there any joined up thinking related to healthy homes and how adaptations are considered?
That's a really good question, and there are lots of different groups that work on that. So even in our local authority, we have a tech-enabled care team. We then have the virtual ward team. We also have our therapy teams and our domiciliary services. Bringing those together into a network is really difficult, but that joined up thinking is starting to happen through projects like this, and that's what we do with our teams, is try and bring them all together and have one conversation, because there are several. Yes.
And one of the challenges, absolutely. So we have questions, a bunch of questions from Paul Tybert. First bit is, he says, I've just managed a pilot for remote monitoring within care homes. 1, how did you identify the correct care homes? 2, how did you engage with GPs who are reluctant to sign up? And 3, what funding did you use in this, as it isn't if it isn't ICB led?
So the funding originally came from a pilot that was born out of COVID, and that pot stayed there. We specifically focused on residential homes, knowing that they relied on a footfall of a workforce going through them, and those numbers were dwindling. They were also a group that didn't always have access to healthcare services and healthcare training as nursing homes did. So for us, they were the most at-risk group, and that's why we focused on them. And we started engaging with homes and building a community with the managers. So we'd go to several providers, and working with our local authorities, started to think about who were they contracting beds to. So there was 2 or 3 different angles that we connected with the homes. One of them was through provider networks, the other one was through contracting, and the third one was from our healthcare colleagues, who each held a top 20 of admissions from care homes. So there was a focus on, could we reduce avoidable admissions, but also how could we connect with those homes. But once we've got managers and teams essentially engaged into this project, because we sat outside of those big organisations, we were able to drive that enthusiasm and that connectivity with them and grow that network at pace. It didn't happen overnight, because nothing does when you're starting to make change, but we needed to take people on a journey, and we took them on a journey with us and the rest of the community at the same time. So we held networking sessions specifically for them as well.
Paul, does that answer your questions?
Paul, if it doesn't, my email's in there, so feel free to reach out.
I'll email you.
I'm sure you've got a lot, so we can have a quick meeting if you want.
Yeah.
Okay, that's great. Thank you. And then we had a question from, let me just find it. So Elaine McClure. So can you give examples of how the £600,000 savings was identified?
Yes, so this was mostly identified through using admission data. We worked on an average length of stay of 10 days. And we calculated that from a level 1 or level 2 bed, and we put an average in there. We also looked at, from the commissioning side of it, how much it costed to have a care home bed empty because somebody was in hospital. So we needed to equally appeal to the providers to get involved with this project. And sadly, financial avenues are often the way into the front door of those corporate floors. But we really also needed to tell the person's story as well, because that is where it really does add value. But from the £600,000, that's where it came from: the admission data, conveyance data, and empty bed data.
That's great. Does that answer your question?
Yes, thank you very much. Thanks.
Brilliant, thank you. We also have a question from Michelle Harvey. Does this data integrate with any patient engagement portals?
It integrates with the electronic health record. I think that's what you're referring to. Across the Midlands, there are several electronic healthcare records. We have System 1 and EMIS at primary care level, and at our hospital level, we have our PAS system as well as Nerve Centre as a system, digital system that runs across all of them. So the main interface for this was to tap into our primary care services, because they are essentially in the middle of the care home and our hospitals. Does that answer your question? I'm assuming you're referring to the electronic health record, but I may be wrong with that.
Hi Tara, it's Michelle. No, but it's interesting to know that it does integrate with the EMIS. What I was thinking is, like patient portals, like for example, like Doctor, where the acutes are using patient portals to share, information with like documents and things and trusts.
So yes, and it's up to the care home really who they interface it with and it's part of Wizan's challenge to interface with as many different portals as they can, and that's the challenge for every provider of this kind of system. Because APIs don't always talk to each other, and equally System 1 and EMIS are very different in the way that they translate an API into the user side of it as well. So it interestingly uses Microsoft Teams when it starts talking into different portals. So, but as a patient, as long as the patient knows their NHS number, essentially, yes, it could potentially interface into any system they wanted it to. The challenge is getting each different system to talk to each other at the back end, and that's around the providers of these systems having their APIs that align, which is why we went down the data route and having news align with everything, and having that clinical story first and foremost.
Okay, thank you.
Thank you, and I'm afraid we're out of time. Thank you, Tara. That's been fascinating, and I hope some great questions from people as well. If you want to find out more, the link to her website is in the chat. So is her email if you want to contact her to have another conversation, find out more in detail. But thank you, that's been brilliant and fascinating, and thank you so much. Please fill in the feedback form for us, for those of you that were here today. Always very valuable to get that so that we can make sure we put on fantastic sessions like this again in future. Thank you, everybody. Thank you, Tara. Any last thoughts or comments from you?
No, I'd just like to say thank you so much, but for equally spending the time to come and see this. But when you do connect with your primary care colleagues, and you do all the time, invite them into your little world and start to have a conversation that goes across the two. And some of that is around picking out the real high points of what it means for both of you within that system, because it's all about patients at the end of the day and how we live well within them. But we are all starting to move between systems. And thank you for coming. So, Jo, I will hang on for a minute, but
Yep, great. Thank you, everybody, and great to have you with us today. And please do complete the feedback form, and we'll see you again at another event, hopefully. Thank you so much. Take care. Have a great rest of the day.